Congenital cardiac physiology. At birth, the fetal circulation undergoes a number of physiological changes that begin with the onset of a spontaneous respiration and cessation of placental blood supply to the neonate. A brief description of these changes can be described by the following. Umbilical arteries close as a result of the muscular contraction of their walls and changes the oxygen tension. Within a few minutes at birth, these vessels are closed. Over the next 2 to 3 months, their lumens are permanently obliterated with their proximal portions remaining patent as the superior vesical arteries and their distal segments becoming the medial umbilical ligaments. Closure of the umbilical vein and ductus venosus follows shortly after the closure of the umbilical arteries. The umbilical vein, like the arteries, fibrose over the next few months and becoming the ligamentum teres hepatis. The ductus venosus becomes the ligamentum venosum and extends between the ligamentum teres hepaticus and IVC. Following birth, SVC increases from loss of flow to the low pressure placenta, which along with decreased PVR reverses the flow through PDA. Vasoconstriction of the muscular wall of the ductus arteriosus ensures that the closure almost immediately after birth, and the process is mediated by changes in the oxygen tension and reduction in prostaglandin E and bradykinin that is released from the lung upon infiltration. Fibrosis of the structure, like those described before, occurs over the next few months. The ligamentum arteriosum is the remnant of ductus arteriosus. As the lung infiltrates, there is a dilation of the pulmonary vascular bed, leading to a decrease in PVR. The decrease continues in gradual fashion from PVR to approximately 8 volts to 2 volts at 8 weeks of age, with the lower PVR blood flow preferentially to the lung rather than through the ductus arteriosus, thereby increasing the blood flow to LA and increasing the LA pressures. This forces the septum secundum against the septum primum and closing the foramen ovale and ending the physiologic intracardiac fetal right to left shunt. The foramen ovale can be reopened with changes in the pressure in the first few days of life. However, consistent opposition of the foramen primum and secundum typically leads to eventual fusion. The neonatal heart has fewer myocytes and more fibrous versus contractile tissue compared with adult heart. It is more dependent on the rate of the cardiac output due to decreased ventricular compliance. Monocytes are more dependent on ionized plasma calcium and due to immature organelles. Lactate is primary fuel for immune myocardium and due to higher baseline oxygen demands and heart functions at a closer maximal capacity. Parasympathetic tone is dominant, predisposing to pronounced bradycardic response in stress. Extracardiac and intracardiac shunts can be localized and measured by invasive means or estimated by imaging. Quantification of shunt is often made with comparison of the pulmonary and systemic blood flow. QP to QS is equal to SaO2 minus MvO2 divided by PvO2 percent by PoO2 percent. QP to QS greater than 1 indicates pulmonary blood flow exceeds the systemic blood flow, and QP to QS less than 1 indicates shunt right to left and demonstrate decrease in aortic saturation. In left to right shunt, in this physiology, the oxygenated blood is returned to the pulmonary circulation and initiate the oxygenation process at a cost of systemic circulation. And in the anatomic, defects exist at the level of the ventricles or the great arteries, and this results in an increase in the venous return from the lung, while the pulmonary veins and LA with resultant LV overload, the increase in pulmonary blood flow and decrease in systemic flow. RV function is gradually spared and decrease in PVR as with supplemental oxygen, nitric oxide, alkalosis or low CO2. Further increase pulmonary blood flow and can decrease in systemic cardiac output. Eventually, continued shunting and pulmonary overcirculation leads to hyperplasia of the pulmonary vasculature and pulmonary hypertension. Reversible pulmonary hypertension suggests that correction of the shunt may facilitate reversal of the disease process, while irreversible pulmonary hypertension suggests the contrary. PVR greater than 8 volts suggests irreversible of the pulmonary hypertension. Unrepaired left to right shunt can progress into the progress of Eisenmenger syndrome. Left to right shunt at the arterial level leads to progressive biatrial enlargement along with RV enlargement and can also lead to irreversible changes within the pulmonary vasculature. These lesions are cyanotic and most commonly VSD, ASD, AVSD, PDA, and presenting symptoms are often related to congestive heart failure such as feeding difficulties or growth impairment. Congenital defects contributing to right to left shunt most commonly result in cyanosis through low pulmonary blood flow, intracardiac mixing of both, and most common cyanotic heart defects in tetralogy of Fallot. Transposition of great arteries, truncus arteriosus, total anomalous pulmonary venous return, tricuspid atresia, pulmonary atresia, hyperplastic left heart syndrome, and a more detailed description of the physiology associated with individual congenital defects can be found in their respective chapters. Overall incidence of the congenital heart defect is 1%, about 15% are identical prenatally. Newborn screening typically involves the pulse oximeter measurement of the right hand and foot to identify the critical congenital heart defect. Echocardiography remains the mainstay method for evaluating the congenital heart defects. Modalities include transesophageal, transthoracic, and in utero for fetal analysis. Cardiac MRI is increasingly used for assessment of anatomical structures, function, and flow. Cardiac specific improvements include ECG synchronization and respiratory synchronization. It is possible to visualize the detailed anatomy of the extracardiac structures, including vascular branching patterns and pulmonary venous anatomy. CT scanning plays a supplementary role but offers a high spatial resolution. CT offers the advantage of more rapid scan. Cardiac catheterization has served as the modality of choice for invasive hemodynamic monitoring associated with evaluation of pulmonary hypertension. Additionally, it can provide useful anatomic information regarding the size and anatomy of extracardiac structures such as pulmonary arteries and aortic arch. Thank you.